Hi, welcome back to Let's Talk Health. Today is the 25th series of the Let's Talk Health series by Star Hospitals. And the topic for today is going to be about trauma and with the focus on how GI surgery is going to be contributing to trauma management. So to talk about this, you have me, Dr. Rahul Katta. I'm a fellow of the Royal College of Emergency Medicine and I'm the group lead for emergency services at Star Hospital. And with me, you have Dr. Aditya.
Hi, I'm Dr. Aditya, a consultant surgical gastroenterologist here at Star Hospitals.
So to begin with, the topic is trauma. What exactly is trauma and what do you mean when we're talking about trauma?
So trauma can be in multiple different forms. So the simplest form of trauma can be just you falling over something and hitting yourself. And predominantly, I guess today, as I'm a GI surgeon, we're going to be talking a lot more about abdominal trauma. And when you look at it, trauma can be multiple things. You can have something as simple as falling over and hitting yourself in the tummy, which is a blunt abdominal trauma. But the most common cause of trauma is actually a motor vehicle accident. Okay? Motor vehicle accidents actually contribute to nearly 80% of all the abdominal trauma which comes in. So this constitutes actually where you have a blunt force to the abdomen and comes under a category known as blunt abdominal trauma. Trauma can also be when you have something which is penetrating the abdomen, which is known as a penetrative abdominal trauma, which can occur in stabbings or impalement injuries. So broadly, these are the types of abdominal trauma which we see in the emergency department.
And what are the different causes that you're talking about? You said most of them is usually a consequence of road traffic accidents itself. What are the other causes of trauma here?
Okay, some of the other common causes of non-motor vehicle trauma are actually sports injuries. You have a lot of people into combative sports and then which is coming up in a big way. So there is a lot of blunt abdominal trauma and thoracic trauma also, which we do come across. A simple act is actually going in a bicycle, falling over, and actually having the handlebar hit you in your tummy can cause a lot of damage inside, especially if you're a child, and result in a lot of multiple intra-abdominal injuries, bringing a patient to the hospital. So these are a few other causes of non-motor vehicle abdominal trauma.
The burden of trauma, particularly in India, is quite significant. If you look at the total number of accidents to the mortality, that is specifically how many patients die as a consequence of it, we are actually one of the worst performing countries in the world. That is a massive problem statement that needs to be addressed. So having good trauma care currently is not just essential, it is fundamentally what's going to make a phenomenal difference with respect to the quality of life we're able to provide to all of us citizens here.
You're absolutely right on this, Rahul, because we all know this whole golden hour of all trauma. And in fact, the first 1 hour after any motor vehicle accident is what is the most important cog in the whole picture. Whereas in India, what we lack is getting the patient to the hospital early. It becomes very difficult. And we also don't have a very efficient ambulance service network. And when the patient does get to the hospital, most of the time he's inadequately resuscitated. Your thoughts on this, Rahul?
I think that's spot on. The biggest challenge is the fact that our pre-hospital emergency systems are quite rudimentary with respect to their approach. Let's be very clear here. The first few minutes to hours, what we do with such trauma patients will make a phenomenal difference with respect to their outcomes. So to begin with, as you mentioned, it is pre-hospital emergency systems. Trauma care has to start at the point of incidence, where the trauma actually occurred, rather than waiting for these patients to come to the hospital, which is why good ambulance services with the right equipment, with the right personnel who know how to use this equipment, makes a phenomenal difference when it comes to trauma outcomes. So that is where pre-hospital systems come into play. In fact, to address exactly this, within the next 7 days, we are actually launching the Trauma Emergency Network. So you'll have a network of close to 14 ambulances that are distributed across the entire city so that we are not waiting for ambulances deployed from the hospital. Instead, the fact that they are spread out, they are closer to where these incidents actually occur. So these ambulances are not only equipped with the right equipment, but we also have senior nurses and paramedics manning these ambulances, providing trauma care where it is actually required. And that is how we need to address pre-hospital emergency services.
And I think what is going to be very helpful for us is having somebody who's trained in this can also tell us about the mode of injury. Once they actually get the accurate details of how exactly the trauma happened, what is the type of accident which has happened, what is the type of injury. If they can gather all this either from the patient right there or from the bystanders who actually witnessed it, rather than it being hearsay, it actually has a lot of importance and gives us a lot of insight on what we can expect and how we can triage these patients.
Absolutely. In fact, that is the whole point of doing all of this. It is appropriate triage. When we talk about triage, all we are talking about is to make sure that we identify the severity of injuries in these patients and make sure that they have access to appropriate resources. It is just matching the demand to what the supply is here. And what we need to do here is, by understanding the trauma profile or how the incident actually occurred, what is the mechanism of injury. And sometimes if we are deploying our resources, like I had mentioned earlier, looking at their vitals like their heart rate, their respiratory rate, their blood pressure, you can triage these patients. You can identify the ones who are very sick and make sure appropriate resources are allocated for these patients. And to deploy this, we are talking about the concept of a trauma call. And what we do here at Star Hospital is fairly straightforward. Based on the mechanism of injury, based on the vitals, or based on the anatomical injuries, we identify these patients that are quite likely very sick already or are likely to deteriorate in the next few minutes to hours, and we put out a trauma call. What happens with a trauma call is we get the subject matter expertise down to the emergency floor. And remember, this can happen when the patient is at the site of the incident and hasn't even reached the hospital. So our paramedics can assess these individuals at roadside, give us an idea of what exactly happened. Based on the mechanism and the physiology, we can put out this trauma call the surgeons down to the emergency department, we call the orthopedicians down to the emergency department. We alert the radiologists, and the emergency team are already waiting for this patient. So this way, as soon as the patient comes to the hospital, all the expertise are already waiting for them, and we do one primary survey. So we do a head-to-toe assessment with all specialties present. And this assessment normally takes about 2 minutes. Sometimes it may take close to 20 minutes, depending on if you need to do any interventions as a result of the injury profile. And by the end of 20 minutes, you have a clear idea on exactly what needs to happen. Do you need to give additional blood? Do you need to take this patient for imaging? Do you need to take this patient to theater? So instead of having broken conversations with multiple specialities and unnecessarily wasting this critical time period, which is the golden hour, we have a clear plan within 2 to 20 minutes. And that is the whole concept of a trauma call.
I think like what you said, that makes a big difference, because previously and all we used to have the ER department separate, and we used to have all the consultants and the relevant surgical teams completely separate. So first the ER team would try to look at the patient, manage the patient, order a set of investigations, and then a call would go out to the concerned surgical teams. And then when they would come in, they would be like, oh no, this is not what I need something else. And then you're going to lose a lot of time. Whereas here, what we end up doing is all of us being together, we look at the patients, identify what we need right then and there, work as a team, see a patient who's hemodynamically unstable, parallelly resuscitate him, get your apt imaging, because the mainstay of all abdominal trauma, if you look at it, is appropriate, good quality, rapid imaging. Okay, these patients take absolute priority, and then a good contrast CT is actually the backbone of all imaging for abdominal trauma, because a negative contrast CT has nearly a 99% chance of excluding trauma and and nearly a 98 or 97% chance of actually identifying any intra-abdominal trauma. Thereby, once you have everybody on board, get your imaging done, you can actually decide upon how you're going to plan the treatment of this patient right then and there. Like what Dr. Rahul was saying, if you have a really hemodynamically unstable patient, this can be one of the cases where you don't even wait for any imaging. You actually rush the patient straight down to the operating room and do something known as a damage control surgery. Okay. When we speak about damage control surgery, our goal is basically to maintain life function. So what is the most critical thing what happens in most of the patients with abdominal trauma? You have massive bleeding. So bleeding is the one which causes the patient to go into circulatory collapse and shock. Shock is because of massive blood loss. So here what we do is we don't wait. We initially try and see that whether the patient does give us a chance and assess whether we can resuscitate him, or if we don't have time, then this whole role of the so-called damage control surgery comes in, whereas we go in, we just pack the patient, we pack in the abdomen, we don't try to repair anything. Our goal is only to arrest bleeding, give us time to catch up with our blood transfusion protocols, give us time to get the patient back to normothermia if he's hypothermic, give us time to secure his airway, basically give the body time to get all its defense mechanisms back in, get the circulation back in, to sustain itself, go back in at a later date and repair and do the appropriate, depending upon the type of damage, the repair which is needed.
I think that's absolutely right. And that is where we are hoping to definitely differentiate ourselves. The truth is this. Most often than not, it is easy to focus on the injury and try to correct the injury. But the truth is this. Most of the data points to this too. Maintaining normal physiology, or in simpler terms, a normal heart rate, a normal blood pressure, a good respiratory rate, and appropriate level of oxygen in the blood actually makes all the difference. And the faster we're able to attain this, the better are the outcomes. And ultimately, that's what matters, the outcomes. And that is the reason why focusing on to damage control surgery, and particularly doing this as soon as it is required, makes a phenomenal difference. Which means we need to make that decision much earlier too. And that is the reason why having multidisciplinary team approach, having all of the specialties together at the point of the initial primary survey itself makes a phenomenal difference, so that we can do this life-saving surgery early.
Well, saying that, most of the time surgery is not required. The funny thing with how we've evolved in treating abdominal trauma is every patient with a blunt abdominal trauma used to land up with a laparotomy, with a big scan, and then we would go in and nearly 1/3 of the time really find nothing. Nowadays, we have good CT scans, which is our absolute backbone of imaging to identify abdominal trauma. And then when we are talking about abdominal trauma, we're specifically talking about trauma to the liver, spleen, the small intestine, the pancreas, the duodenum, and the large bowel. This is how we look at it, and the mesentery. Most of the non-hollow viscous, when we talk non-intestinal trauma these days, is managed conservatively. Even depending upon the grading, even if you have a severe grading, especially even in the liver and the spleen, if we have a hemodynamically stable patient, we do manage them conservatively. These are also patients where if we do identify bleeding, which is happening within the liver or the spleen during the initial CT, now we don't go ahead and operate immediately. We have the expertise of calling in our interventional radiologists and actually blocking off these blood vessels right then and there, and thereby stopping the bleeding and preventing the patient from losing more blood and going into shock. Okay. This is again the this is again wherein the whole trauma team comes in, whereas it is not just our surgeons, not just the orthopedicians, not just the ER, anesthetists and all. We also have good interventional radiologists who we call on to help us control bleeding right then and there without reducing obviating the need of a laparotomy.
And I think that's the whole idea, isn't it? The fact that you have this level of expertise available that quickly in the initial hour of resuscitation itself gives you a much holistic approach. It tells you what patients are sick, what patients are likely to deteriorate, and what is the best modality to address this patient. Instead of relying on one single subject expert, the idea is to make sure it is truly multidisciplinary so that end of the day, the patient always comes first. And that is the best way of dealing with trauma, particularly complex trauma. One other question that I have is, most of what we're talking about right now, we're talking about blunt trauma because this is a significant portion of our trauma population. How about penetrative trauma? Can you talk a little more about that, what it is and how do we treat it?
So when you look at penetrating trauma, we have two components. One can be a stab, whereas you have somebody who's been punctured, whose abdomen has been punctured either one time or multiple times. And you might also have an impalement injury where you have the patient brought in with a huge rod sticking out of his abdomen, which has happened multiple times. Now, how do we deal with these patients? Let's take the patients who've come in with a stab. Now, what we need to determine here is what is the type of the weapon which was used, what is the direction of the stabbing. This is important because it kind of gives us an idea of what kind of structures would have been injured, what type of an injury to expect. Invariably, yes, all these patients do require an imaging with a CT scan, and what we usually also do is explore them bedside to assess whether the musculature has been breached. If the abdominal musculature has been breached, it is highly likely that these patients are associated with an intra-abdominal injury. Traditionally, all these patients did require an laparotomy where we would actually open up the abdomen and try to find out. These patients also had like a 25-30% rate where they did percentage where they did not have any intra-abdominal injuries. Thereby, here comes in the role of serial imaging. We do an imaging at admission. We follow up the patient, look for clinical signs. We look for signs such as abdominal tenderness, distension in the abdomen, any enteric contents which are draining out from the stab wound site. We don't suture it up. We always leave these wounds open. If any of these do happen, this is an indication for us to take the patient up for surgery. If not, 24 hours later or 48 hours later, depending upon the clinical scenario, we repeat an imaging, and there is a few percentage of patients who we can manage like this and get away without doing a surgery for them. Then comes the patients who come in with an impalement. These are actually like you can have a construction worker, which is very common when they fall onto these iron rods at the construction site, and then the rods are cut and they're brought in by their peers with the entire rod sticking in through and through their abdomen, through their chest, through their legs, through their thighs, everywhere. Now, these patients are very unique because if you try to pull the impaled object out, this object can actually would have gone through a blood vessel and could have actually compressing it, and this object being inside his abdomen is actually keeping him alive because it is not allowing the bleeding to happen. The second you remove this object out in an uncontrolled fashion, you're going to lose this person. So this is where we need to actually innovate. We need to figure out how to image these patients, but actually imaging is not very reliable because you get a lot of artifacts in imaging. This is where a lot of clinical judgment comes in, because wherein we look at the way the object has gone into the abdomen, try to assess and actually figure out in our head what are all the injuries which could have happened. These are the patients which we always take them into the theatre and under full control go in, secure all the surrounding blood vessels where the impaling object is through, and only after that remove it and then and there repair any of the damage which has happened. So this is a very unique subset which is there, wherein we actually advise everybody, if you see somebody impaled, don't try to pull it out. Leave the object in place, bring the person to the closest hospital. You're actually saving his life. You trying to remove it is not going to do him any good, but it's going to do a lot more harm.
That's actually a very important point. Remember, particularly when you're dealing with trauma, there are only 2 or 3 steps that you would need to remember as a layman. Whenever it's a road traffic accident, it's just 2 things you need to do. One is immobilize the patient. Make sure they are not moving their neck, they are not moving any part of their spine. So it is immobilization, which is step number 1. And 2 is control any bleeding. If you see any obvious bleeding from anywhere, apply pressure and try controlling it, and then quickly call for help. And as Dr. Aditya mentioned, particularly with respect to penetrative trauma, whatever object is impaling them or is actually causing said penetration, make sure you do not disturb this object. Leave it as is and call for help early. By following these simple steps, you will be able to safely transfer these patients to us in the times of their need.
Rahul, I recollect that lady who was brought to us in severe hypotension, which happened just when we started the hospital, just when we were getting the trauma team together.
Yes.
When we had this lady who was, I think, a 30-year-old girl,
Yes,
who was
very young.
brought with a runover injury. Runovers are again a particular subset where we do anticipate a lot more damage to happen, because there's usually a lot of crushing force involved and shearing forces also. So we can expect a lot of intra-abdominal injuries and thoracic injuries to happen. Well, we had this 30-year-old girl who was brought to the ER, and then at around 8:30 or 9 in the evening, we get a call saying so-and-so person is being brought in. And I think when she came in, she was absolutely hypotensive. And then as a part of resuscitation, she had blood on flow, and then while imaging her, she actually arrested on the way to the CT scan. She was revived. A lot of blood was rushed in, a massive transfusion protocol was followed. And then we stabilized her. We didn't do anything else. We just waited for 3-4 hours for her to stabilize. And then as we were doing it, we could still notice that her abdomen was slowly getting turgid. Here it makes it very important for the same person who actually examines the patient right when she's brought in to serially examine them over a period of time, because you're the person who can actually judge what is happening. The whole concept of having abdominal girth, measurement, and all that is kind of outdated. Right now, we can actually do an intra-abdominal pressure measurement, or the simplest thing like the same person examining the patient again and again gives us a lot more information. Well, coming back to this lady, we waited for 3-4 hours, we resuscitated her, and then we took a very bold decision of actually trying to go ahead and pack her. So that is the whole concept of damage control surgery. There was a lot of debate whether it was going to be worthwhile even taking her to the theatre, because she actually suffered a cardiac arrest, her heart did stop, there was CPR given, and then her heart had restarted. So after a lot of back and forth, we did take the bold step of actually opening the abdomen, where there were around 3 liters of blood with a large blood clot in the abdomen. And then you could see that the hepatic veins were lacerated. We didn't try any heroics. All we did is we did a proper hepatic packing. This is something we employ when you know that there's a lot of damage which has happened to the liver. When you look at the liver, it's a nice, soft, friable organ. And then when there is trauma to it, it becomes like jelly. It just comes apart like putty in your hand. So you can't really go ahead, suture to stop bleeding or do anything. So here we actually use our own body's ability to heal itself, added with a little bit of pressure. So pressure stops bleeding. So what we do is, we did is actually just pack the liver nicely. Ensured that there was no other intra-abdominal injury anywhere. We looked at the bowel. That's what we do. Whenever you do go ahead, once your bleeding is controlled, you do a secondary survey again. Try to see if there's anything else which you can quickly repair and get out. Well, she did not have anything else. We packed up the abdomen, closed the abdomen, brought her to the ICU, and within 6 hours, you could see that her need for almost all inotropes was coming down. 24 hours later, she was awake. We waited for 48 hours, took her back into the theatre, and by this time, all we needed to do is just remove all the packs we had used, give her a good wash to the abdomen, all bleeding had stopped. Close the abdomen, come out, next day she's ready to eat. No heroics, taking a good decision, on going ahead, resuscitating in spite of her having a cardiac arrest, giving her enough time between the arrest and taking her to the theater for her to stabilize a little bit, taking a bold decision of packing and not disturbing and doing more harm than good, coming out, giving her enough time for her to settle down, and once she's completely stabilized, going in, removing in all the abdominal packs, and then we have a patient who is ready to go home 2 days after the next surgery. So this was literally, if you can think about it, a second life for her.
That's absolutely true. And I think this story is particularly a very good example to illustrate exactly what we have been talking about. I mean, proof is truly in the pudding here. So early assessment, transfer to CT, and at this point of time, I think when they were transferring her, she appeared to be quite stable. But just the sheer movement of moving her onto the CT itself must have dislodged the clot that caused her to go hypertensive and then bleed out. So you can see how sensitive this patient is. Immediately identifying that this patient is unwell, started with CPR, replacing blood for blood, massive transfusion, early call to take this patient for surgery, and particularly, as Dr. Aditya said, damage control surgery. No heroics, pack, control the bleeding, close that tap, stop the blood loss. And that is what saved this person's life. And there's no better example than this young lady who did extremely well and in fact spoke to all of us after this surgery just a week down the lane. And that, ladies and gentlemen, I think makes a phenomenal difference, and why multidisciplinary team involvement is so essential for having good trauma care.
Because the funny thing with now, when we like the management of all abdominal trauma right now is a lot more non-operative. So we are seeing a new subset of complications which do happen. When we look at hepatic trauma, so what can happen is the bleeding can stop, but the liver also produces bile. You can also have bile leaks. And these do not manifest till around 2 to 3 weeks down the line. So you're not going to have blood loss, but you're going to have secondary complications which can arise. Now, how do we deal with these? This is where our medical gastroenterologists actually do come in, where they do wonderful ERCPs. Okay, relieve the pressure on the ducts and then reduce the amount of bile leaks. Our interventional radiologists also have a great role, because how we manage these bile leaks are by placing percutaneous drains. Initially, these required surgery. Now, we use a CT scan, identify where all the bile is collecting and put in a drain. Because once we start draining it all out, that is when they usually dry up by getting fibrosed. If they do not happen down the line, we might have to go in again and remove that segment of the liver, but that's a different story. But then, usually, most of the time, they settle down with these simple measures. Another thing what we see is, initial trauma happens, we manage them non-operatively, especially in the liver and the spleen, we have pseudoaneurysms. What exactly is a pseudoaneurysm is where, when you have a blood vessel, a portion of the blood vessel gets damaged. During the part when it's healing, what happens is that portion of the blood vessel bulges out as a bubble. And then it's like a small balloon which is ready to give way. As time goes by, it starts growing bigger and bigger, and these can suddenly rupture, leading to massive hemorrhage, which may usually happen usually between the 10th to 20th day. Most of these patients whom we manage non-operatively, that's why we do call them back in 10 days later, we repeat an imaging, which is very important. Following up all these traumatic patients, repeating an imaging after 10 days. If there is a pseudoaneurysm, this is our IR team again comes in, they go ahead and then embolize them non-operatively and then take care of all these aneurysms.
Thank you for sharing that. I think that particularly talks about not just the importance of early trauma care, but even post-op management, or even when it comes to conservative management, the continued management of these patients is also very important, because each patient can be relatively unique with respect to how they respond to such treatment, and which is why it is very important for us to keep an eye on such patients and also track their progress to make sure that our treatment is truly comprehensive. Any other parts, or any other aspects of post-op care that we would need to consider, particularly the audience might need to know?
So if you look at it, if we do take up a patient for surgery, most of the surgery is usually done in an unstable patient, or when there is frank enteric injury, when there is a bowel perforation, where that is 100% indication for a surgical intervention. So all these patients also have a high likelihood of developing postoperative adhesions, and there's always a high likelihood of developing a wound infection. So the continuum of care is always going to be there to make sure that the wound heals well, infections are taken care of. Most of the time, abdominal injury is associated with other injury where there can be injury to the extremities or thoracic injury. These patients, because when associated with thoracic injury or even a simple abdominal surgery, have difficulty breathing later and due to pain and develop atelectasis. So the role of a good physiotherapist is very paramount because we want these patients to be mobile. We want them to do their spirometry, their deep breathing exercises to make sure that they don't develop a small lung collapse, which is known as atelectasis, and develop postoperative fever, which can prolong their stay in the hospital. Down the line, a lot of the abdominal injury patients also can develop other complications such as adhesions in the abdomen, which can cause something like a small bowel obstruction, which can happen, which again is treated conservatively most of the time, but may require repeated interventions because all the intestine while healing gets stuck to each other. So these are some of the complications what we can expect down the line in a patient with abdominal trauma. Well, Rahul, we've spoken a lot about abdominal trauma. I think prevention is always better than cure. Do you have any thoughts on this?
Absolutely. I mean, given the current burden of trauma, a significant portion of this, especially where the mortality actually exists, is road traffic accidents. And their prevention definitely is the key. So the idea is fairly straightforward, ladies and gentlemen. Buckle up, drive safe. It saves lives, not just your own, it's also the people who are around you.
Thank you.
Thank you.